biopsy, the radiology has been already covered. So what I will do, I will straight away go to the management. So something about these tumors. These malignant tumors are very rare tumors. They form less than 5% of head and neck tumors, and they are histologically very diverse. So if you see, I mean, there are lots of types of tumors. There can be epithelial tumors, there can be respiratory mucosal tumors, there can be salivary gland tumors arising from rose and parasitic sinuses, there can be mesenchymal tumors. So there is a lot of variety of tumors which are seen in this area, and sometimes it is very difficult for the pathologist to actually diagnose. So what you need is a very good experienced pathologist who can actually do immunocytochemistry also and give you a diagnosis. So many times what happens, you take a biopsy, it is like squamous cell carcinoma or undifferentiated carcinoma, and final biopsy is something else. It might be a SINO-NASAL tumor of undifferentiated malignancy, or it could be a olfactory neuroblastoma, or in fact lymphoma. So we recently had a patient whose biopsy was esthesioneuroblastoma pre-operatively. The final biopsy was lymphoma. So it can be very, very varied, and what you need is a very experienced pathologist. Diagnosis and management is also very challenging because of the surrounding areas. We have important areas. The orbit is there. We have the intracrinial cavity. So any tumor which is going into the orbit or intracrinial cavity makes the diagnosis as well as the management very challenging. Diagnosis is also often delayed. Why there is a delay in diagnosis? Because it is all closed cavity. We have maxillary sinus. There is a tumor which is growing into the maxillary sinus. Patient will not know or will not have any symptoms until unless the tumor comes out of the maxillary sinus. It will just keep on growing inside the sinus, and the symptoms will be just like chronic rhinosinusitis, like pain, sometimes some nasal discharge, maybe sometimes a blood stain discharge. So these are very, very similar to a chronic rhinosinusitis patient, and often the delay is almost 5 to 6 months once the patient comes to you. So there is a delay in presentation and survival rates. If you see the survival rates for last maybe a decade or 2 decades, survival rates are almost similar. Like they do not change. It's 50%, 5% of all these animals. Etiology, so I will not go into details of etiology. Much has been talked about the viral etiology, HPV and EPV, smoking, hard to softwood exposure, nickel and industrial exposure, fumes exposure are there, and males are more affected, and it is more seen in white. So this has also been covered. The types of malignancy which we see in the SINO-NASAL tumors, the most common is squamous cell carcinoma, but it only forms around 50 to 20%. Rest of the other tumors are there, so we can have variety of epithelial tumors. We can have adenocarcinomas, salivary gland tumors, mesenchymal tumors, and then secondary tumors. So I'm not going to the details, but this is the classification which has been recently given by WHO. So this is a WHO classification that gives you almost 50 types of tumor which are there in SINO area. So maxillary sinus tumors are the most common: ethmoid, sphenoid, and foraminal frontal sinus. Okay. I will not go into details of the clinical examination. Presentation, okay, early it is very, very non-specific, but later on what happens, it basically presents with the involvement of the particular wall of the maxillary sinus. If there is the involvement of the anterior wall, patient will have anterior neck, cheek swelling, lower palatal wall, palatal swelling, orbital involvement, there could be corposes or visual disturbance, epiphora, medial wall involvement, nasal symptoms will be there, and if it goes into intracrinial cavity, there will be signs of nerve involvement. So there is a foramen rotundum, there is a foramen, this medial canal, right? So all these symptoms will be anesthesia and paresthesia of the cheek and in the area of pancreas. And so advanced diseases, the patient usually present with advanced diseases, and these are this presentation of a tumor of a SINO-NASAL malignancy, and the clinical presentation will depend on the area which is involved. So I will not give the details of it in sake of time. Radiology we have already covered. I just want to tell you something like tumors like this has an intracrinial connection, and it is very much enhancing. Even image, there is a lot of water content in the tumor, so probably say very conceptual which is communicating with the brain, and radiology is very important. So if you take a biopsy of this patient has C-cell virus. So you have to be careful. CT scan, this has been already covered, so I will not go into details. Again, sir has already told you CT and MRI complementary. Whenever you are dealing with a sino-nasal tumor, any tumor limited to the bony walls of maxilla or nasoethmoidal regions, you can get a CT, but anything which is beyond sinuses, please get an MRI done, because that will give you much more extra information of the involvement of the internal cavity and the organs. We want to this biopsy is also done. So clinical staging, we have this is the latest AGCC 8th edition classification, and you see T4A and T4B. T4A tumors are resectable tumors. Any tumor which is going into the orbital apex, involvement, involvement. These are not resectable tumors, and probably if you try to just debunk these tumors and try to treat this patient, you are giving much more harm to the patient rather than treating this patient, because the survival rate is not at all different. So it will be same. So rather than you have to select your patient very carefully whether it is a resectable tumor or not. If it is a resectable tumor, then only you try to resect. Otherwise, these patients can be given sent for concurrent chemoradiation. Tumor which has a very extensive locoregional control, locoregional spread, can be given for new adjuvant therapy, so that it is more easily accessible after the therapy. Right. So, what is the management? So, I will come to the management. Primarily, it is surgical management. All sino-nasal tumors you have to manage surgically. By surgery, surgery is curative for all resectable tumors. But it's prohibitively morbid, because when you are doing a surgery for a sino-nasal tumor, you probably are removing part of the maxilla. So there is a cosmetic deformity, patient is not able to speak properly, patient is not able to drink properly, eat properly. There is an involvement of the orbit, so you remove the orbit, again lot of emotional trauma to the patient, as well as loss of orbit and then cosmetic deformity. So we need to plan the surgery, and we need to reconstruct the orbit as well as the palate. We have to think about that. And if you see the management, the surgical management can be divided into two broad categories. One is the tumor which is arising and limited to maxilla, and another set of tumors which are actually in the nasoethmoidal region. So we can divide these two, this management into two different categories, right? So we will come to the surgical part, the maxillary part, right? So the maxillary part, if you see, if the tumor is in the maxilla, it is very difficult to do endoscopic surgery. You have to do an open surgery, and open surgery is either through the transfacial approach or through oral cavity. Very, very rarely you can actually do a transoral surgery without any facial incision, and that is called as transoral approach. And tumors which are limited to the infrastructure or a palate can be done by transoral. Otherwise, 99% of the maxillary tumors you need an open approach surgery. Right? Very rarely, as Dr. Vashist has shown, if a tumor is involving the medial wall of maxilla, you can do a medial maxilla. So again, very less role of endoscopy in maxillary tumors. So types of surgery, we can actually classify maxillary tumors surgery in inferior maxillectomy, subtotal maxillectomy, total and extended. And sometimes you can actually use endoscope also. Sometimes when you have a large tumor which is going from the maxilla into the ethmoids, you might use an endoscope to assist clearance of the tumors. Okay. So what are the incisions? So this is a picture which I took from latest TEL-MERA. I mean, it is authored by one of our Indian surgeons, Dr. Prathamesh Pai. So this is a very beautiful picture. So what you see here is all the facial incisions which are used for maxillary sinus tumor removal, right? So if you have, see, it is a vessel-percussion incision with superior labiatory, right? And then this is the part of the, this is basically the lateral anatomy incision. This is superior labiatory. Then you have a Lynch extension. You can have a subciliary extension, or you can have an infraorbit extension, depending on whether you want to preserve the orbit or whether you want to excise or remove the orbit. And then you can also have a bicoronal incision, which is actually for craniofacial sections. So this is a patient who actually had squamous cell carcinoma, and the tumor was actually going to the orbit, and there was a frank orbital involvement. We decided to do an orbital exenteration, right? So you can see the incision which has been marked. There was some erosion of the eyelid, so we have actually removed the part of the eyelid also, right? So have a good oncological clearance. The Weber-Furtado incision was marked, flap was elevated, the whole maxilla was removed along with the orbit. So that is the surgery which is done here. If there is a skin involvement, obviously you need to actually reconstruct the skin part also, and here this patient actually had skin involvement, and we excised. Again, this was a transfacial incision, Weber-Furtado. The whole tumor, which was an en bloc section of the tumor with the orbit, and it was prepared by forehead flap. Right? So we did not actually take a DP, because DP will not reach the upper margin of the orbit. Sometimes if you have the expertise, you can actually use a free flap. Right? A free flap, like a ventilator thigh flap, has the advantage of providing the bulk also. Right? Because a folded flap is just a cover which is providing, but because you have removed lot of tissue and the maxilla has been removed, you need a bulk also. So in those cases, a free flap with an ventilator thigh is a good option. But again, if you don't have an expertise or you don't have the support of plastic surgeon, so total mastectomy with orbital exenteration, few important points. Consent is very, very important, and frank periorbital involvement is an indication for orbital exenteration, and discuss with the pathologist, very, very important. Because what happened when I was like senior resident, maybe there was a patient who underwent orbital exenteration with mastectomy, and the pathologist has reported the eyeball as normal. So the patient came to me with this report, कि डॉक्टर साहब eyeball तो normal, आपका eyeball क्यों निकाला? Right? So what is happening here? It is the periorbital which is involved. The eyeball is not involved. If there is a periorbital involvement, if there is an extra ocular muscle involvement, you have to do orbital exenteration. Right? The pathologist was also right in a sense that she actually had seen the orbit and it was not involved. But the indication of a surgery in this patient is not eyeball involvement, it is periorbital involvement, because the eye cannot survive without the periorbital. Right? So you have to actually talk to the pathologist that they should not be writing such reports. They should be writing that there was involvement of the periorbital tissue, or the muscle involvement was there, orbital muscle involvement was there, or periorbital tissue was involved. Right? So that is very important as far as medical legal things are concerned. Right? So always have a discussion with the pathologist that they should not be giving such reports. Affects involvement. If there is an extraocular muscle involvement, if there is a connective or scleral involvement, and if there is a lid involvement which is beyond reconstruction, you have to remove the organ. Where it can be preserved, there is a periosteal involvement. So again, if there is a periosteal involvement, excise the part of the periosteum and send it for that is a frozen section to know what is the extent of involvement and whether the margins are clear. Limited fat or periorbital involvement you can preserve here. So there is now a more trend to preserve orbits, and that is done only by the help of frozen section in top. If they are negative, then probably you can preserve them. And also one important thing, only when you are able to resect the tumor completely from all over the parts of the maxillary sinus or the SINO-NASAL area, then only you should do orbital exenteration. You have done an orbital exenteration but left a large part of tumor in the ethmoids or into the skull base. There is no point in doing orbital exenteration, because the survival rate of a tumor which you have left microscopically is same as if you don't do a surgery. Right? If you are not doing a surgery, and if you are doing a surgery and you have left a large microscopic portion of tumor behind, then there is no point in doing a surgery in a SINO-NASAL tumors. Right? So only do a orbital exenteration when you have 100% surely remove tumors from the other areas of the body. Because what you are doing, you are giving a cosmetic, non-functional, you are taking away the function which is very, very important. You are taking away the eye of the patient and without cleaning the disease from the other areas. Right? So that is what I will suggests, right? So this is the algorithm. So you take a biopsy, craniofacial dissection, laminar preparation eroded, you send the tumor adjacent to the periosteum for frozen section. Dissection of periosteum is positive. If the tumor is going, on the other side of the periosteum, you do orbital clearance. So if the periosteum is clear, you do a orbital preservation, and if it is a recurrent, then again you have to do a orbital clearance. So that is the thing. I will come to nasoethmoid tumors. So earlier for nasoethmoid tumors we were doing Lynch-Howard incision, external ethmoidectomies, but now with the advent of endoscope, the trend is more towards endoscopic surgery, right? And we can do endoscopic clearance of a nasoethmoid tumor. For example, this tumor which is just limited to the ethmoid and the nasal septal area, right? So what we do for an oncological clearance, we need to actually remove the tumor along with the whole of the ethmoidal gallery with the mucosa. So that is important. So you need to have a clear margin of the tumor, which we have excised, right? And again, the skull base. So if it is actually going to the skull base, you have to remove the part of the skull base, the bone which is in adjacent to the tumor, we have also to be removed, and is also to be removed. And what we do here is basically we debulk the tumor. First step is to debulk the tumor and create space, working space on all the sides of the tumor. The tumor dissection is actually from periphery to the center, right? It is centripetal dissection. You have to create a plane of cleavage all around the tumor without compromising the margin. So that is the main concept of a tumor dissection in a SINO-NASAL area, right? So what you do here, debulk the tumor, then you take the septum on the other side and start dissecting, right? So because septum on the other side is intact, right? So the tumor is located on the right side, you start dissecting the left side and do a septal incision, right? From the other side, and then you progressively do a ethmoidectomy and go till the laminar preparation. So you remove the periosteum, the mucosa, all the mucosa from the laminar preparation. Complete removal of the laminar preparation mucosa until you reach the skull base. And from the skull base also you have to remove all the mucosa and then deliver the tumor in totality, right? So that is the complete ethmoidectomy, and perform centripetal dissection and then gradually come towards the center of the tumor. That is the concept. And once you have removed, suppose you have removed a part of the skull bone, skull base bone, you have to do a reconstruction, and the reconstruction can be done by various methods. If you have, in most of the tumors of the SINO-NASAL tumors, you actually tend to remove the part of the septum. So probably the Hadar flap will not be available for reconstruction, and you need to do a two-layered, either a facial atta or maybe temporal fascia is a small defect. Large defect you need to have a facial atta for reconstruction. Or extended dissection is done whenever it is needed. So if there is a need for doing orbital exenteration, you can do a combined approach, remove the orbit open with open surgery and remove the part of the SINO-NASAL tumor endoscopy. So this is the picture actually taken from the latest this telegram, and what you see here is basically the same patient, same picture. It is the same. Basically, what you are doing is do a tumor debulking, then you do a nasal septal management, complete ethmoidectomy and skull base management, and then reconstruction. So what you see here is the opening the skull base, and this is after complete dissection. The tumor has been completely dissected, and there is a large skull base defect along with the dura. Bone as well as the dura has been removed, and then you do a reconstruction, which is basically by temporal fascia or facial atta. So there are two terms which are very important. One is en bloc dissection. So we have already seen en bloc dissection of the matrix sinus with the orbit. So that is complete en bloc dissection. But what you can do is you can do in these tumors, you can do a multi-block dissection. What you understand by multi-block dissection is that you remove part of the tumor as well as the mucosa and the bone, keeping the margins intact, right? And then do a second removal of the bone and the dura, right? So it's a multi-block dissection, and it's a sequential resection keeping in mind the principles of oncology. Right? You never actually cross the margin of the tumor by doing a multi-block resection. Right? So again, this is a multi-block resection specimen. So what you see here is a tumor. This is the tumor, and this is resected along with the lateral wall of the nose. Again, this is a septum, and this is the lateral wall. So we have removed the middle turbinate, the tumor, the superior turbinate, and the nasal septum all along. Right? So this is the one piece of tumor which has been removed in first stage. In the second stage, this is again the same specimen on the lateral side. In the second stage, this is the part of the bone in the skull base which has been resected. So it's a multi-block resection, and this picture is actually taken. This is the quadrant picture, and this is from the cranial side. The same specimen from the cranial side. And what you see here is the bone with the depression. These are the olfactory fossa, the fox cerebri, and this is again olfactory cleft, and this is the vestibular. So this specimen is again a second excision which has been done. First excision was the tumor along with the lateral wall of nose and the septum, and second sequential surgery was basically removal of the skull base with the bone, right? And if the dura is involved, you will remove the dura also. So that is what is multi-block resection, right? So en-block resection and then multi-block resection. Multi-block resection can be performed in patients with nasopharyngeal tumors. Okay, so if the tumor is going intracranially, then again we need to do craniofacial resection. So craniofacial resection, you have to approach by bicameral incision, elevate the flap, and we usually preserve the pericranial flap for reconstruction. Right? So that is important. Do a craniotomy and open the MBS skull base, retract the frontal lobe, and go into the pubiform plate area where it is communicating with the nasal cavity. Right? So you again do this approach is done by neurosurgeon, and from lower part from the nasal side you actually do an endoscopic approach or an open approach depending on the type of tumor and the expertise available. Right? So this was one of the patients who actually had this 55-year-old patient, olfactory neuroblastoma. This we actually excised in collaboration with the neurosurgeons. Right? So this patient was not kept in our OT. It is basically kept in the neurosurgery OT. So they do a craniotomy from above, and we remove the tumor from below. Right? So that is the concept of craniofacial resection. Again, this was the final meningioma which we excised with a combined approach. Okay. Regarding the surgical margins, so I was talking about surgical margins, right? See, negative surgical margins and microscopic positive surgical margins, you have a good survival. But if you are leaving behind macroscopic tumor, then there is no benefit of surgical treatment at advanced stages, right? So including nodal metastasis over non-surgical management, right? So that is very important. If you are trying to remove a SINO-NASAL malignancy, you should be looking towards a complete removal of the tumor, at least macroscopic. If you are leaving a macroscopic tumor, there is no point in doing a surgery. So planning is very, very important. You just see the tumor extension and plan accordingly, and it depends on the surgeon expertise also. Whether I might not be able to remove a tumor which is going maybe into the skull. There are surgeons who can actually do. So it depends on the surgeon's expertise also, whether he is able to or whether he is capable to remove that tumor or not. Right? So please don't venture into a tumor which you are not, which you are sure that I am not able to do. Right? Macroscopic tumor, you cannot leave a macroscopic amount of tumor behind. Neck dissection, most of the nasal SINO-NASAL tumors will not have a neck node, but if there is a neck node, you have to do a combined neck node dissection. How much time I have? 5 minutes? I have? Yes, you have. Okay, so role of neoadjuvant induction chemotherapy, right? So it is indicated for tumors which are locally advanced tumors, locally advanced SINO-NASAL carcinoma and SINO-NASAL undifferentiated carcinomas, which sir was talking about. So all these tumors are very, very aggressive tumors. So do a neoadjuvant chemotherapy. And the aim of the therapy is to escalate the treatment in very aggressive cancer, chemo selection, orbital preservation, and improvement in surgical margin. And the most common regime which is followed is cisplatin and 5-fluorouracil, and you can add taxane. Right? For neuroendocrine tumor, etoposide is the drug of choice. Right? So that is for the neoadjuvant chemotherapy. Injection chemotherapy, if you see this paper, it says that there is an overall better survival rate, 2-year better survival rate if the patient receives injection chemotherapy. As far as orbital preservation is concerned, 66% of the patient had orbital invasion at the time of induction chemotherapy, and only 18.3% patient require orbital examination. So, neoadjuvant chemotherapy can actually preserve orbits. Post-op radiotherapy, so most of the patients will require post-op radiotherapy, right from T2 to T4 lesion. It's only very select T1 lesions which have been resected with good margin that you can avoid radiotherapy, but 99.9% of the patients of SINO-NASAL malignancy will require post-operative radiotherapy. This is the table which actually shows you the role of radiotherapy. So all the squamous cell carcinomas, advanced cystic carcinomas, SINO-NASAL undifferentiated carcinomas will actually require radiotherapy. And in case of unresectable disease, obviously, because you don't have no other option to provide the patient with radiotherapy and so there is a role of proton therapy and carbon ion therapy. Right? So this paper actually shows that the carbon ion radiation is superior to proton therapy in management of SINO-NASAL malignancy. Okay, for local regional recurrence, again, if there is a recurrence, the patient comes to you with a recurrence to see whether it is resectable or not. So you can give him a choice of surgery if the tumor is resectable, and if it is not, then it is to be re-radiated or maybe palliative therapy. Rehabilitation is very, very important. So if you have the expertise, plastic surgeons can be called and you can rehabilitate. People are now doing upper alveolus reconstruction by fibula, double barreling with fibula, and they are able to put teeth also, but again it depends on the expertise of these surgeons. Prognosis and survival, overall survival rate I already told you 50% in the last 3 decades. Male patient and older patient have worse prognosis, higher staging of T and N has a worse prognosis. Histologically, if you see, olfactory neuroblastoma and non-advanced cystic carcinomas have excellent long-term prognosis. Because the melanomas and neuroendocrine tumors have poor prognosis, high-grade tumors have poor prognosis. Residual disease, macroscopic residual disease, no advantage over non-surgical treatment. Microscopic residual disease, positive margin, worsen prognosis in almost all. These are 2 very, very important statements. We must follow this. Treatment-related factors, again, surgery, skull base and neural involvement the surgery should be tailored to the extent of the tumor, right? And orbital invasion again has a poor prognosis. So, thank you very much. If you have any questions.